Good morning. This is Babak, Larian, and we are doing a live question and answer session on primary hyperparathyroidism. Fortunately, we have lots of questions that have come in that we can go through and discuss and answer any questions you guys may have. Hopefully, these sessions are helpful and you can use it to your benefit. Hopefully this empowers you to talk to your physicians more effectively so that if you are affected by this disease, you can make a better case for yourself, because I know a lot of you find it difficult to maneuver and navigate this challenging, difficult disease and get treated. You know, it can be very hard. It's a challenge. It truly is a challenge, which is why I'm here. In any case, let's go ahead and start. I'll start with the first question that comes from Keith Hayworth. I'm Keith, and my wife Allison has been diagnosed with primary hyperparathyroidism. She's on anticoagulants, blood thinners, for life due to a mechanical mitral valve for reasons of calcification. Okay? So because she has a mechanical valve, she has to be on blood thinner so she doesn't form clots that'll flick off and go to her brain and cause a stroke. When reviewing primary hyperparathyroid subjects' serum calcium levels in considering surgery, and hers is above 2.85, should vitamin K deficiency due to the use of warfarin or synthron justify a lower trigger value due to the increase in vascular calcification? It's not the vitamin, no. Keith, you're asking a very good question, but you're also almost asking the wrong person. I'm not a believer in a certain value for calcium being a trigger point for doing surgery. I know that's what the International Workshop on Hyperparathyroidism suggests, and so let me explain. So every couple of years, this group, the International Workshop on Management of Asymptomatic Hyperparathyroidism, gets together. So I emphasize this is for asymptomatic people who have no symptoms at all. Right? And they say if you have no symptoms, right, these are the guidelines for when you should have surgery, right? And the guidelines are, in 1990 was one set, 2002 it changed, 2008 it changed, 2013 it changed again. I think we're due for another change. It's been a decade. So what they said in the U.S. system is that your calcium should be 1 unit, excuse me, 1 unit above normal. It used to be 1 to 1.6, and they changed it to 1 just to make it a whole number. Then they said you should have bone loss or osteoporosis, and then they changed the guideline for osteoporosis from -2 standard deviations to 2.5. In the latest iteration, they said the bone scan, the DEXA scan, is not good enough to look at your spine. So in addition to a bone scan, you have to look at the spine in more detail by doing other studies, right? They also should looking at kidney function. If the kidney function is hampered, you should have it done. If at some point 24-hour urine calcium was in, 2008 they took it out, 2013 they put it back in. So you can judge that for yourself. In 2013 they said you also have to have scans to prove you don't have any kidney stones. And then they also said the age, if you have 0 symptoms and you're under the age of 50, you should have surgery because you have a long life ahead of you and you should be treated. What do they base these findings on? Well, 1 unit above normal is a strong recommendation, and it says low quality evidence. There's no evidence that 1 unit above normal. So whatever they say in England also about the threshold for doing surgery as being something is based on very low quality evidence. There's actually no proof that that is a differentiator, right? A lot of the symptoms are caused by high calcium. A lot of the symptoms are caused by PTH. A lot of the symptoms are caused by your body adjusting to your higher calcium, so your other organs have to adjust to that organ, adjusted to the higher calcium, and they themselves adjusted to another calcium. So it's a big cluster of things happening, and you are just adapting, every organ adapting, every part of your body adapting to new calcium, new PTH, and each other. Complex. So simplifying to 1 unit above normal is almost nonsense, and they say it, low quality evidence. Osteoporosis, strong recommendation, high quality evidence. So yeah, if you have osteoporosis and you have hyperparathyroidism, we know for a fact that if you have a successful surgery, you have a very high chance. Some studies even show 100% chance of improving your bone density, right? So that is definitely something to consider. Next is kidney function. It's a weak recommendation and low quality evidence, right? So 24-hour urine calcium being in and out, most patients don't have 24-hour urine calciums that are above 400 unless they're very late in the disease or their kidney is already hampered, right? If you have kidney disease and you have hyperparathyroidism, then you obviously are going to address it because you don't want to increase the load on your kidney, right? But the evidence that if you're functioning kidney-wise and your 24-hour urine calcium is slightly high, but your numbers in terms of kidney function is borderline, is weak, because they say weak because surgery doesn't, if you have a bad kidney, doing parathyroid surgery doesn't make your kidney better. It may slow down the process of getting worse because the kidney is already damaged, but it's not going to make it better. So that's the low quality evidence. Bone osteoporosis does get better, right? And then the last recommendation, age above 50, strong recommendation, moderate quality evidence. They say that because, well, obviously, the younger you are, the more lifetime you have ahead of you for this disease to impact you. So, makes sense, but why not 60? What is this age of 50 based on? These were based on life expectancy outcomes in the 50s and 60s, which is obviously dramatically different. Older people are living healthier lives now. And so a lot of these things are, so Keith, the reason I said this is because if your wife is having symptoms, don't look at the calcium value as a deciding factor to treat her. Look at how much of an impact this is having on the quality of her life. Obviously, having calcifications in the blood vessels and having had a valve replacement is a huge factor affecting the quality of her life. Being on blood thinners, it is also. If you can kind of separate what's associated with that problem and what's associated with hyperparathyroidism and see the impact of this disease on her and then make a decision, all right? And then you have to look at the ups and downs of surgery, because if she's going to have surgery, then she has to come off the blood thinners, go to the hospital, be placed on heparin intravenously, which will be stopped an hour or two before surgery. She has the surgery and it's immediately started again, so there are inherent risks with surgery as well. But sitting down with a surgeon and looking at the pluses and minuses is what's going to help you, not the threshold of calcium. Best of luck, my friend. Best of luck to your wife. Mary Elizabeth, the specialist that I went to see that states that there is a concern for normal calcemic hyperparathyroidism. Okay, 6-month follow-up. She does not recommend surgery, too risky. 1.5 glands left after 2008 surgery. I do have symptoms. May 11th, 2022. Calcium is 9.2, PTH is 59, vitamin D is 53. Ionized calcium 1.21. So calcium on the low side of normal and PTH on the upper side of normal in this particular lab. And March of 2022, calcium was higher, 9.8, PTH was 70, This was ordered by the endocrinologist, October 2021. Calcium 9.6, PTH 46, vitamin D 38, ionized calcium. Okay, she actually went by the corrected calcium levels. So I was and still am confused. Going through my PCP currently is 6 months too long to wait to repeat labs. So let's try to break it down, Mary Elizabeth. If you had a surgery in 2008 where they removed 2.5 glands, that means that they probably found 3 of your 4 glands. They didn't see the 4th one. They didn't want you to risk the fact that you only had 3 glands, because 3% of people have 3 glands. So if you don't find your 4th gland and all 3 glands look abnormal, they're gonna do what's called a subtotal parathyroidectomy, which means removing not the total of all the parathyroids they see, a little bit less, removing 2.5 glands, leaving half of the 3rd gland in place, with the presumption that potentially you may not have a 4th gland if they didn't see it. Because if they see all 4 glands and they see 3 of them are abnormal, there is no reason to leave half of an abnormal gland behind, right? So the presumption is that you had parathyroid hyperplasia, right? They took out 2.5 glands. You potentially have half a gland or 1.5 gland left, right? Based on the information you give me, that's kind of what I'm gathering, right? And that's what I would have done myself, right? Obviously, I would have checked PTH during surgery, which may not have been so readily available in 2008, but we'll leave that alone for now. And if you're listening, you can try to shed some light if I'm not thinking correctly, right? So if you have parathyroid hyperplasia, that means all of your parathyroid glands are abnormal, right? So in a setting of an adenoma, let me show you the adenoma picture. In a setting of an adenoma, instead of having 4 parathyroid glands, with each gland having but roughly 4 million cells in it, right? All of them set for the same calcium level, producing the same amount of PTH in response to your calcium level, up and down, right? On the other hand, when you have a parathyroid adenoma, you have 1 gland having a tumor growing, producing a lot of PTH, raising your calcium up, and because your calcium is going up, the other 3 parathyroid glands that were larger now are working less, so they shrivel up to use up less energy, right? Okay, that's adenoma. In a setting of hyperplasia, what you get is, in setting of hyperplasia, what you have is all of the parathyroid cells in all of the glands are abnormal. And they are based on the rate of growth and the level of activity of the different types of cells in a hyperplastic gland, all abnormal cells. You're going to have some glands that are bigger and some that are smaller, right? And so in this setting, you can't cure this person. They're all abnormal cells in there. You can reduce the number of abnormal cells, right? And maybe take half of this gland out. So you're left with half of an abnormal gland, which produces only enough PTH to service you, right? And that's the idea, right? That's really the philosophy behind what's happening, okay? So if you had your surgeon only find, if your surgeon didn't see this one, all right, let's say this one is in your throat somewhere, and the surgeon didn't see it, and comes in and sees these 3 glands, there's 2 options. They can take all 3 glands out and check your PTH, right? And if your PTH goes to 0, re-implant half of this back in to the muscle and hope that you fit into the 80% that it works and not in the 20% that it doesn't work, right? Or if the PTH doesn't go down and you can't find it, say, well, okay, well, you've had 3 gland removal, you have 1 gland left somewhere I can't see, we're gonna leave it alone. So if you have PTH available, PTH testing, that's an option. Or the other option is to, instead of taking, again, this one is in the throat, instead of taking all 4 out, take the largest 2 and the smallest one, cut it in half, right? And take out the half, leave the other half in place, right? If you have PTH testing, check it. If you have an appropriate drop in your PTH, then that may tell you, that the only thing that tells you is that the amount of parathyroid cells you've left behind is adequate enough to produce enough hormone for you to function properly, and not a lot for you to be overactive, at least in the near future. Nobody can tell you how fast this half a gland, let's do it in blue, this half a gland that you left behind, and potentially that 1.5 a gland that's left behind, is going to grow to get you back into hyperplasia, into hyperparathyroidism. So you have hyperplasia, how long is it going to take before they get large enough to get you in trouble, right? So, Mary Elizabeth, again, with the presumption that you had a subtotal parathyroidectomy in the setting of your surgeon having seen only 3 glands, you have either half a gland left behind or 1.5 a gland. You have 1 or 1.5 gland of hyperplastic cells, abnormal cells. So you have persistent hyperparathyroidism. Your numbers seem to indicate that your calcium and PTH are not following an inverse relationship, because when your calcium goes up, your PTH doesn't come down, and when your calcium is down, your PTH doesn't go up. They kind of are doing something that's not really responsive to each other, right? So because, again, October of last year, calcium was 9.6, PTH was 46, a little bit above mid-range of normal. In March of 2020, your calcium went up to 9.8, your PTH went above normal. In May of 2022, your calcium went down to 9.2, and your PTH came down to 59, right? So instead of going like this, they're doing this, which is not responsive. So you have hyperparathyroidism, you have parathyroid glands that are not functioning properly. You can do more labs, and I would encourage you to do a comprehensive set of labs to look at the pathology report of your previous surgery, look at your operative report to see how many parathyroid glands your surgeon saw, right? All of those things are very important, because it gives you a better picture of where you're at, and if my theories about what happened with you are correct. But I have a feeling you have persistent hyperparathyroidism. My question to you is, how much are they impacting you? What is your bone density doing? Are you having bone loss and more osteoporosis? In which case, you have to address it, right? Now, you may address it by having surgery, which can be risky, right? Or by taking Sensipar, bringing your calcium and PTH numbers to a lower level and seeing if you feel better. And I think in your particular case, because there's an element of uncertainty about what was done during your previous surgery, how many parathyroid glands you have left functioning, and an element of trepidation, which I certainly understand, then trying Sensipar to see how you feel is important. Because if you try the Sensipar and you feel significantly better, right? And you have no side effect from Sensipar. And side effects from Sensipar are nausea and headaches, mostly, right? And you feel like, you know what, I don't have any symptoms, I feel like $1,000,000, I now have an option of continuing my medication, Sensipar, or I can do a risky surgery. Or if you feel better from all these symptoms but you have nausea, you can see what your quality of life would be staying on the medications or doing surgery and not having the nausea, right? It gives you options. So I think that may be a good option for you to exercise. Talk to your endocrinologist about a trial. of Sensipar rather than waiting for Godot. You're having symptoms. You don't need to have labs that are showing fantastically wrong numbers. Your numbers are already not proper. Okay, best of luck, Mary Elizabeth. Barbara Zalora Wilson. I think Keith Hayward just sent me a message. Keith says, thank you for giving your answer to my question. We should be having a consult with a surgeon soon. The impact on Allison's quality of life symptoms associated with PHPT is really poor, so we hope that surgery is agreed despite the risk. Listen, Keith, I think if your surgeon doesn't want to do surgery, you also have the option of doing Sensipar, right? And if you do Sensipar and you see quite an improvement in the quality of Allison's life, then that could be another thing you could say to your surgeon. Say, you know, another option for you guys as well. Hey, I tried the medication, I'm better, I'm not having nausea, maybe Allison shouldn't do surgery, considering the valve issue, and we'll just continue the medication if it's not giving you any other problem. So it applies to, Sensipar applies to both you, Keith, I'm seeing Allison, your wife, Keith, and Mary Elizabeth. And a lot of you, you know, that is an alternative option when you have uncertainty about your circumstances that is worth exercising. Now moving on to Barbara Zalora Wilson. My thyroid was ablated in 2009. I had hyperthyroidism. So I'm assuming you had radioactive iodine. Taking thyroid medications, had 2 parathyroids removed in 2015, both upper parathyroids. And had continued severe bone pain for about 3 years, went everywhere, no one could explain, have taken calcium ever since, and magnesium, all good for the last couple of years. In August 2021, had 1 Prolia shot, never again. PTH was 140, at upper range of normal 70, when follow-up tested in December. August, okay. Along with high cholesterol, wicked bone pain, fatigue, hair loss. Follow-up testing in January, February showed PTH was normal, ionized calcium slightly high. Surgeon said, not unusual with Prolia. Yeah, it isn't unusual to get elevations in PTH with Prolia. I mean, however, it is now back up to 140. Serum calcium normal, ionized calcium slightly high. Vitamin D dropped from 70 to 50 because I cut back the amount I'm taking. Bone pain gone, but now my teeth hurt terribly. I'm told teeth pain is from high PTH. High PTH, who knows why, but don't even think about a second surgery, just increase vitamin D. Drive PTH down. Maybe it's going up and down because of last year's shot. Does any of these make sense? Do teeth really hurt from high PTH? Or Prolia? So your questions are, does any of this make sense? Do teeth really hurt from high PTH? They can, because high PTH causes bone loss, so your bones are losing some of the calcium. So it could be that you have tooth pain from the tooth losing calcium or from the bones where the tooth are sitting in losing calcium. So it can happen. It's not a very common thing at all. Very, very uncommon. Have you ever seen bone pain continue for so long after thyroid surgery? Well, if your bone pain is a specific site of injury, then it wasn't due to PTH, yes. But if you're having multiple areas of bone pain and they come and go and they're alternating site, then that's PTH related. And if you had a successful surgery, then it should be gone. The fact that you have an elevated ionized calcium and a high PTH now tells me that you currently look like you have hyperparathyroidism. So I would urge you to do your blood tests Again, do calcium, PTH, ionized calcium, 25 vitamin D, 125 hydroxy vitamin D, and a 24-hour urine calcium. Do it at 8 o'clock in the morning and fasting. Make sure you're not taking any biotin supplement, okay? Because that can interfere with blood test results. And once more, a week or two later, just the blood test and not the 24-hour urine calcium, fasting again. So you can get some numbers that are unaffected by other environmental factors, so you can put it into perspective. If you continue to have an elevation in calcium or high normal calcium and a high PTH like you're having now, then you have hyperparathyroidism. You have 2 parathyroid glands inferiorly. I'm not sure what they did during the first surgery, if they even saw them or not, but you may have persistent disease or recurrent disease and you have to address it, okay? And should I pursue a second opinion surgeon to address the high PTH? Yes, you should. You should get your old operative report and pathology report. You should make a table of your calcium, PTH, and vitamin D over the years from your previous surgery till now, from 2015 till now, right? Put the data clearly in front of your surgeon, right? Us surgeon types have short attention spans, and if you don't present your case well, it's like a court case. You're presenting your position, then they may lose interest and so on. So you want to go in strong, right? But if you can get all these things that I'm saying in advance and put it in front of your surgeon, then you have a better case. All right? Or just live with it, because I do realize some people have it. No, don't live with it because other people have it worse. Your quality of life matters. You matter. Make a strong point for yourself. Don't give up. Definitely don't give up, Barbara. And if you want me to look at all your stuff and kind of put it into perspective for you, you're welcome to contact my office, and I can take care of it for you. All right, sweetheart. Shanette Torley. I have just had a second surgery to find parathyroid. The surgeon found it deep down between my trachea and esophagus. The histology showed it contained parathyroid hormone. My calcium PTOs have come down, but I'm still having pain in my groin, rib cage, and hands, and pins and needles at the back of my shoulder and arms and my feet. What do you think I should do next? My surgeon is sending me for a CT scan. Does it take time for the pains to go away? With my last calcium reading was 4.33. Shanette Torley, I don't know what the range for your calcium is or what unit you're using. So I don't know what 4.33 is, if it's high or low. And my last PTH was 78. I'm assuming your PTH range is 15 to 65, which is most labs range. But I need more information, sweetheart. If you can give me some more information, then I can give you a more educated answer. So if you're watching, if you can post that up right now, I can give it to you. I can give you my thoughts on it. But you had 2 surgeries. It's important for me to know what they did during the first surgery, how many glands were removed. Obviously, second surgery, they had 1 gland removed, but did they touch any of the other glands or biopsy them or anything else? What your PTH numbers did during surgery? A lot more information for me to give you an educated answer. So hopefully you're listening, and hopefully you can shed some light so I can actually give you an opinion that's worth a penny. Sin Mill, what happens when PTH is normal and calcium high and vitamin D level low? Told to stop vitamin D for a month to see what happens and retest PTH, calcium, and vitamin D. So when PTH, so you have normal hormonal hyperparathyroidism, right? So you have to look at other causes of elevated calcium, right? So causes of hypercalcemia. Obviously, hyperparathyroidism is the most common cause, right? So you look at other endocrine glands. You have to look at the PTH-related peptide, PTHRP, because some tumors produce it. You have to look at the bones and see if there's any bone loss. So alkaline phosphatase shows bone metastases in a blood test. Multiple myeloma, which is a bone cancer, bone marrow cancer, can cause it. So you have to do what's called an SPEP, SP as in Peter, E, P as in Peter, SPEP, to look for that. Vitamin D intoxication can cause it. So your vitamin D being very high. So if you've stopped the vitamin D and you feel better immediately, then that could be it. Sarcoidosis, which produces a compound that's similar to vitamin D. You have to check ACE levels to see if that FHH, which you can figure out with the 24-hour urine calcium. But FHH could do it, right? If you have, with FHH, you'd have elevated in calcium, PTH would be in the normal range, but your 24-hour urine calcium would be significantly low. These medications can increase your calcium level. Kidney issues, being in bed and immobilized, or getting food through IV can cause it too. So these are the things you have to look at, right? And that's a comprehensive workup, Sin, that you need to have, not just, okay, take less vitamin D and see what happens, right? You want to make sure. I'm not trying to scare you. I'm just saying you got to be thorough and complete to get to an answer, right? I don't think you've had enough of a workup to know what's going on. Now, you stop the vitamin D, and if that immediately changes everything and you're okay, then good. But it seems like you still have symptoms, so I think you need further workup. All right. Next one is Kelsey Pollard. Thank you for running another one of these. My pleasure, Kelsey. I had an appointment with you last week. Based on my labs, calcium is 8.9, PTH is 81.2, calcium was 9.5, PTH 78, calcium 8.6, PTH of 113, right? So you have low calciums or low normal calciums, or maybe sometimes even low, and your PTH is always elevated, right? But the lower your calcium gets, the higher the PTH gets, okay? You said, I do have normal calcium hyperparathyroidism. You went over the slide with me on possible causes of secondary hyperparathyroidism, since these have to be ruled out with normal calcium levels. Can you please the slide to go over the Okay, absolutely. All right, so we're going to normal calcemic hyperparathyroidism. And the infamous slide, and this is it. So, causes of not primary normal calcemic hyperparathyroidism, causes of secondary. Things that secondarily increase your PTH level, right? And not necessarily your calcium. So vitamin D deficiency can cause it. Low calcium intake, which would show up on a 24-hour urine calcium, right? Renal calcium leak. These are patients who have very high 24-hour urine calcium. They have a normal or low blood calcium levels. Sometimes they have history of kidney stones, but not necessarily always easily treated with a diuretic hydrochlorothiazide. Kidney disease, so looking at your kidney function, medications. These medications can cause it. Prolia. And then you would have to stop taking the medications and see if things corrected. Malabsorption, so if you have celiac disease or gluten intolerance based on an antibody attacking your intestine, so you have to do this blood test to check for tissue transglutaminase antibody. Low magnesium levels can cause it. Another thing that can cause this is in the postmenopausal setting, it has been discovered that vitamin D is less active in the intestines in helping you absorb calcium. So if you have a low 24-hour calcium, you may want to go on a trial of not regular vitamin D, but activated vitamin D, rocalcitrol, which is a prescription strength medication. Now, I'm not certain if the reasoning for all this is that you have poor Here, let me take you to a slide that'll help clarify what I'm trying to say. I don't know if the reasoning is that calcitrol is less active in the intestines in helping you absorb calcium, or if the process is that your kidney has less activity on activation of inactive vitamin D to active, right? And so doing blood testing where you check your 25 hydroxyvitamin D and 125 in addition to calcium and PTH can help guide you, because if your recalcitrol is low, definitely giving yourself recalcitrol will help. If your recalcitrol is really high, then that's probably not going to do it. But if your recalcitrol is either low in the normal range, taking recalcitrol to see if that helps you better absorb in the intestines can be a way of trying to see. So one thing that's not included in that chart is potentially using recalcitrol to see if that can help you, okay? So moving on, we also talked about my 24-hour urine output being high, 297, with the range being between 100 to 300. Would this number change based on calcium in my diet that day and supplements? If so, is this worth testing again, paying close attention to the amount of calcium in my diet in the week leading up to it for the test, or this? No, I mean, let me flip this around. You're asking a very good question, Kelsey. Unlike most of you who are very intelligent and trying to figure a very complex issue, you are doing the same, so I applaud you for that. I mean, yes, that can be acutely affected by having calcium in your, so we have these calcium sensing receptors in our parathyroid glands and in our kidney. They are set for a certain number, right? So let's say they are set for a calcium of 9.0, all right? If your calcium is 9.5 in a normal environment, the parathyroid glands will produce less PTH because your calcium is too high. They want to let the kidney filter it out. The kidney also has the same calcium sensor set for 9.0 and realizes the 9.5 is too high and filters a lot of extra calcium out to help you get back down to 9.0, right? Now, if you get hyperparathyroidism because of a tumor in the parathyroid gland, and this, instead of being set for 9.0, is now set for 9.5, the kidney is still set for 9.0. So the kidney tries to get rid of the excess calcium. However, PTH counteracts that function in the kidney a little bit, so that's why you don't always find elevated calciums in your urine when you have hyperparathyroidism, right? But when you do, that means your kidney, despite the PTH, the excess PTH from your parathyroid glands, instructing it to not let go of the calcium, it's still doing it because it finds your calcium to be super excessive. Could that be influenced by you having a lot of calcium in the 24 hours period where you were collecting it? Yes. So if you want to be on a low calcium diet for a week and then do it and see what that number shows, that can give you additional information that's helpful. I find that to be very intelligent and a good question, Kelsey. So I would suggest that you go ahead and do that. So I love it when you guys think of something to ask, something that I may have not even mentioned or thought of, right? And it proves to me how great we as a community are together, right? Anyways, moving on to Allison Kennedy. Is it possible to have abnormally high PTH and calcium in blood above normal NHS range? NHS is the National Health Service in England. Osteoporosis at 2.9, but not enough showing on the 24-hour urine test. Yes, I think I just explained it, Allison. I think the sequence of Kelsey and Allison was perfect. And not have hyperparathyroidism because of the urine test. The urine test does not prove you have hyperparathyroidism or not. It doesn't. In those consensus guidelines for asymptomatic patient, it's used to say you should have surgery or not, but a weak recommendation. What it does when I have it helps in two settings. In someone who has normal hormonal hyperparathyroidism, so they have elevated calcium, normal PTH, looking at the 24-hour urine calcium allows me to figure out if this person has FHH, which is familial hypocalciuric, low calcium in the urine, hypercalcemia, high calcium in the blood, which means that their kidney has a condition that is not a disease, just a condition where it filters less calcium, so it's the calcium backs up in the blood. It has to do with the calcium sensing receptor in the kidney and the parathyroid gland, so the calcium setting is higher, right? And they are normal. They just have a higher setting for calcium. There's nothing wrong with these guys, right? Sometimes they can be symptomatic, but usually they have no symptoms and they're totally okay. So it helps in that setting, or in the setting where the numbers are not clear, like Kelsey's. If Kelsey's calcium in the blood is low, 8.6, but the 24-hour urine calcium shows that their calcium is on the upper side of normal or elevated, then that tells me that the kidney recognizes that 8.6, 8.9 to be too high. Now, Kelsey's smart, saying, I'm going to cut out calcium out of my food and do the 24-hour urine calcium, so I'm not influencing it by taking too much calcium in my food. Very intelligent. She's eliminating outside factors to see, because if she repeats her blood test and her calcium is 8.6, PTH is 100 plus, and her 24-hour urine calcium is still 250 or higher, then she knows that her kidney recognizes the calcium of 8.6 as being high, right? No one's going to tell her, no, you have secondary hyperparathyroidism because your calcium intake is too low. Your kidney's telling you your calcium is not too low. It's filtering a whole lot of calcium out, right? And so that's where you stand, okay? Very good question. But the 24-hour urine calcium is not used to decide if you have hyperparathyroidism or not in clear cases. So in your case, you have high calcium and high PTH, and you have osteoporosis. You don't have an unclear case, you have a very clear case. So whatever your 24-hour urine calcium is inconsequential in your diagnosis, all right? Except if it was very, 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 very low. There are some people who have FHH and they have high calcium and just elevated PTH, and then maybe a vitamin D factor in there, right? But good question, Allison. Hopefully this helped. Pam Davis. Hi, Pam. Good to hear from you. I had a consult with you in 2019 and you recommended surgery. I now have a third of the gland left. Recently my PTH jumped, so that means you had hyperplasia for everyone else. Pam had hyperplasia. She had 3 2/3 of a parathyroid gland removed, and now she has only 1/3 of a gland. My recent PTH jumped around 118 with normal calcium. I'm on 2,000 milligrams of calcium and 5,000 of vitamin D daily. My endocrinologist says this is secondary hyperparathyroidism. Before that lab work, I was taking around 1,500 of calcium. So I was told to make sure I took 2,000 in a month. In a month, get labs again. The lab bullet came back with PTH around 64, but my calcium dropped to 8.5. I've always been normal calciumic. Any thoughts? I think your endocrinologist needs to see your 24-hour urine calcium, because if she thinks you have secondary hyperparathyroidism because of low calcium intake, right, then your 24-hour urine calcium should be low, right? And if you've always had normal calcium hyperparathyroidism and you had to have surgery for it, right, and your parathyroid glands under the microscope looked abnormal, so you had hyperplasia, You have still a third of the parathyroid gland that's abnormal and hyperplastic. You still have abnormal glands, and if they grow large enough, they're going to give you a hyperparathyroid state. Your version of hyperparathyroidism is normal calcemic, because probably your natural set point for calcium is significantly lower than the numbers that we are accustomed to seeing, so we have a hard time interpreting what you are. So I would say do a fasting calcium PTH vitamin D, 25 hydroxy vitamin D, 125 dihydroxy vitamin D, and a 25 urine calcium. And look at the magnesium and other things as well, but do those things so you can prove to yourself and your doctor what your kidney is recognizing as appropriate calcium levels, right? Go from there. And you may want yeah, let's do the blood. Pam, let me know what it shows. You have my number. Just let me know what these labs show. We can take it from there. All right, my dear. Anyways, moving on to Mary McQueen. Hello, Dr. Larian. My newly found friend Elaine Cole from the Hyperparathyroid UK said I should ask you about my condition. I'm from the UK and have been very ill since before Christmas. I've had to beg for tests. Started with low backache and irritable bowel. I had low sodium and creatinine, yeast infection, now very low iron. Pain in the back has moved up to the spine with moderate spondylitis changes. I asked for PTH tests. My D was 78, PTH was 8.3, calcium 2.46. I think in the UK, the upper normal for PTH is 6. So 8.3 is high. I don't remember what the upper limit of normal for calcium is, but I think it's 2.6. So your calcium is on the upper range of normal and your PTH is elevated, and vitamin D is normal. Your latest PTH is 7.8, again elevated, calcium is 2.53. So calcium is a little bit higher than previously, your PTH is a little bit lower, but your PTH is still above normal. My previous calcium was 2.59. I've got L5 fracture and was told 25 years ago I had osteopenia. Wow. I don't know your age, but I would assume 25 years ago you were too young to have osteopenia, unless you're 100. My question for you is, does this sound like normal calcium hyperparathyroid? Are any of my symptoms connected to it? Should I be taking calcium and D as I've been advised? My GP's happy to. My GP's happy the PTH is coming down. I want to retest in 6 weeks, but from what I've read, it's not a downward trajectory, but just a fluctuation. Correct. I agree with you. It looks like a fluctuation. I would again advise you to have your GP who's cooperative to do the labs in 6 weeks. Again, fasting at 8 a.m. and get calcium, PTH, ionized calcium. All right. 25 hydroxy vitamin D, 125 dihydroxy vitamin D. Get magnesium level. These are, again, what you're looking for, because you fit into that infamous chart. This one. You want to get a 24-hour urine calcium here. You want to look at your kidney function. You want to look at magnesium. And you want to look at tissue transglutaminase antibody, right? So those are the labs I would suggest that you get in 6 weeks, so you have more information to come to the answer of if you have normal calcium. You know, and you say you're worried that you're losing the battle here with your doctor and feel that he doesn't understand. Again, what I would say is go to the website, go to the parathyroidmd.com website and download this worksheet. So this worksheet, which has your symptoms and everything, put in your labs, and then this has the workup for normal calcemic hyperparathyroidism and workup for normal hormonal, right? And I would say, since you fit in the normal calcemic, the only other thing I would say you need besides these is tissue transglutamin. It's hard to write on a moving surface. Minase antibody, right? Glutaminase antibody, right? But again, you can download. This isn't on the sheet. I'll try to add it on at some point, but that's what I would suggest that you do. Okay? All right. Moving on. Floyd 261 from Instagram had all 4 parathyroid glands removed. The surgeon attached a piece of the parathyroid gland to a muscle, hoping it would begin to function. 5 months have gone by, but it's still not functioning. I take calcium, vitamin D, and oral calcitrol per day. Is there any hope of the gland starting to function? I've seen it start to function as late as a year, so you still have another 6 months. You know, as time goes on, the chances of recovery becomes less and less, Floyd. So I wish you luck. Hopefully it works. That's why I'm not a fan of removing all 4 glands when people have hyperplasia. I'm a fan of leaving half a gland in place with its blood vessel intact, checking the PTH in the operating room, because I don't want to replace hyperparathyroidism with hypoparathyroidism. And I tried my best to do that. It doesn't always work out. You know, hyperparathyroidism is a complex things. So then I have another one saying, responding to Floyd, Betsy's heartstrings. I think I'm assuming Betsy's your wife. I am so sad for your situation. My sister had, no, she's not. Her picture is with another man, Floyd, so no, not your wife. Anyways, sorry guys, I'm just seeing the Instagram pictures here. Anyways, my sister had 6 enlarged parathyroid glands. Wow. You aren't supposed to have 6 glands. True. I've actually taken out 8 glands in a person, and they still have hyperparathyroidism, so they have more, but nonetheless. And her surgeon, not the surgeon in the post, a different parathyroid center, only left a small piece. It took her a few years before things got working correctly. Like you, she took calcium, vitamin D daily. I should ask her how she seems to be doing now. It's been a while since she's specifically talked about it. 4 of us siblings had surgery in 2018. It was crazy. Well, you know, Betsy and your heartstrings. If your sister had 6 abnormal parathyroid glands, she had hyperplasia. When you have hyperplasia, it means all the parathyroid cells are abnormal in all the glands, which means that it runs in families, more likely to run in families, which all of you had. So you all probably have had hyperplasia. I'm glad you guys have addressed it, but it's very encouraging to hear someone had recovery of function after 2 to 3 years, so it should be encouraging to you, Floyd, and thanks, Betsy, for sharing it with the rest of us. I haven't seen it take that long, but I'm glad to hear that it can. Lily Star 143. After parathyroid surgery, what to expect? What's the tumor-free adjustment period like? And for how long does your body take to adjust to the new normal after surgery? So this is a question that's doesn't have a clear answer. What I've noticed over the years is that if you have only bone pain as your only symptom, bone pain is the only thing that you suffer from, you will have that be gone in the recovery room, right? And if that bone pain is not caused by injury, it's caused by hyperparathyroidism. That's the only symptom that you know consistently when and how quickly it's going to be gone. Recovery, right? It's phenomenal because those patients think you are the greatest thing since apple pie. A lot of the patients who write these reviews about me and other doctors are the ones who have almost exclusively or mostly bone pain, and it gets better and their life is changed phenomenally. Unfortunately, the rest of the symptoms do not follow that because bone pain is purely and utterly caused by PTH, right? And when your PTH goes down, the bone pain magically goes away because PTH is causing your bones to release calcium. So they're losing calcium on a regular basis, and that remodeling and shifting of calcium causes pain in the bones, right? It's like the growth plates that we had changing your bones as we were growing on, and we are having growing pains. So in a sense, you're having shrinking pains, not growing pains when you have osteoporosis, right? All other symptoms follow a different trajectory because they're not purely caused by PTH or calcium being high alone, right? So I tell my patients, the time it takes for you to get better has to do with two factors that I've seen. How long you've had the disease. The longer you've had the disease, the more you've adapted to the new calcium PTH, the more your organs have adapted to each other's and their new normals. So the longer it takes for them to readapt. And the higher the difference between what your calcium was and your natural. So if the difference between natural calcium and the calcium you have is little, you've had a lot less adaptation going on for your body. But if the difference was wider, you have a lot more adaptation. There's a study that came out of Yale that showed that neurologic symptoms, memory loss, poor sleep, irritation and things like that, well, not sleep, but irritation, anxiety, and mental issues had more to do with PTH. So the higher the difference between your pre-surgery PTH and their post-surgery PTH, then the greater the improvement you've had in your neurologic symptoms. PTH has a neurotransmitter-like property in the brain. So that's what I would say dictates it. So I can't give you a clear answer, but those are the functionalities. So with respect to that, our superpowers are healing and adaptation. That's what makes us amazing and special, right? And so the more you force your body to adapt, the faster your recovery will be. So I know it's hard to go through these recovery periods, but the more you're active and you exercise in different types of exercises, so you're challenging your body in different ways, right? And different mental exercises, from crossword puzzles to other types of mental challenges and reading and so on, the more you force your body to adapt and recover its functionality. So that's what I would encourage. Lily, sorry. Betsy's here too. It can take a while to adjust in some ways. My bone pain was gone within a few days. There you go. My brain fog seemed to lift and float away like a dark cloud had been hanging over me for years. I kept seeing improvements for 2 years afterwards. So many things improved. I still need to get more healthy. After years of feeling horrible, some of it's habitual fear that I won't ever feel well again, I think. Chronic illness is such a... Betsy, you are a godsend. You're amazing because your answers are so spot on. Thanks for sharing. Lily responds, I have like stomach pain, like a punch in my gut. Could be anxiety, but I never had it. It comes and goes. It's bizarre. Never experienced it before. Also, I sleep all through the night now, which is amazing, and my gut health is a lot healthier. Betsy's response, I'm sad about your stomach. That is no fun. I have major stomach pain with anxiety, but my anxiety had been so much less since my surgery 4 years ago. My sleep is better, and I'm so glad you sleep through the night. It sure is nice, isn't it? It sure is. Thanks for the discourse, Lily and Betsy. It's all true. Your recovery is very variable. There's no two people who've recovered the same way. You know, everything is different, and there's too many factors affecting it. Lily, I do believe that the stomach issues probably have to some extent to do with anxiety. And anxiety, there are three things that cause increased acid production: diet, lack of exercise, and anxiety. And so if your anxiety is happening to you in spurts, which all patients who have hyperparathyroidism have more anxiety. Now, some people are anxious to begin with, and there's a sky high, and some people are like Marley, and as relaxed as can be, and when their anxiety level is higher for their level, they're just like normal people's regular apprehensions, and so they don't seem overwhelmed by anxiety, right? So it's relative anxiety that matters, but relative anxiety to your body is still impactful. So you could have acid production increase and cause you upset stomach, or you can get spasms of your muscles around your stomach or the valve above your stomach because of anxiety, all right, or because of acid issues. So anyways, so the punch in the gut could really literally be anxiety or acid or a mixture of both, okay? So good luck with that. All right, let's move on to the questions that came in during our talk. Teresa N. Van Pelt says, Cinecalcel helped me while I waited for surgery. Phenomenal. Teresa, if you're still on, can you share with us if you had any side effects from the Cinecalcel? Aaron Jureb. Dear Dr. Larian, you might recall we had a consultation a few months ago. My son, CDC73 genetic mutation, had 3 parathyroids removed in 2020, one which was 3 centimeters large, very suspicious for carcinoma since PTH was over 500 and calcium 3.5 plus. Now after a year and a half, calcium is 2.13, PTH is 60. Can I safely say there is no risk or any possibility of cancer cells left behind? I don't know about safely, but I think with a great degree of confidence. Parathyroid cancers are notoriously non-forgiving, so they don't stay behind and rest. They grow, they increase, they just keep producing PTH, and so it seems these numbers are very promising, right? But it doesn't mean you shouldn't keep a very close eye on your son. Keep checking your labs. If it was my son, I would check him every 3 months and look and put the numbers on a table and continue. But these numbers are very encouraging, I would say. Okay? Good to hear from you. All right. Linda Frey, scheduled for surgery with adenoma found on sesame V scan. PTH and calcium high for several years. Vitamin D is fine. I've had hypothyroidism for years. Surgeon mentioned my thyroid was very small, and asked if I'd ever been told I had Graves' disease at our consultation. I have not. I didn't ask him to expand on it, just wondering why he would think that and what are the impacts of a small thyroid. Well, Graves' disease is when you have a hormone, an antibody that your body produces, which attaches to the receptor on the thyroid gland, where the thyroid stimulating hormone from your brain usually attaches to stimulate the gland to produce extra hormone. When this happens, your gland produces excessive amounts of thyroid hormone. You become hyperthyroid, right? And the treatment for it is radioactive iodine. Radioactive iodine shrinks your thyroid gland, right? So it produces less thyroid hormone, but people who've had radioactive iodine to treat Graves' disease have an increased risk of developing hyperparathyroidism. They have an increased risk of having multiple abnormal glands or hyperplasia. They can have multiple adenomas or hyperplasia. So I think that's why your doctor was asking to see, indirectly to see if you've been treated for radioactive iodine. Now, when someone has hypothyroidism, which means their thyroid gland is not producing enough hormone, right? If they take thyroid hormone replacement, Synthroid, because the gland doesn't have to work, the gland also shrinks. Everything in our body that is not working shrinks, right? Like your muscles. So your body is based on pure efficiency. It wants to be maximally efficient. And so when you don't use something, it becomes less functional, smaller, weaker. Just like your muscles. Just like unused parathyroid glands when you have an adenoma overworking. All right, hopefully that helps you understand. Cleo Conway Benson. I had severe pain in my teeth on the right side of my mouth. After my parathyroidectomy, my tooth pain disappeared for good. So there you go. Cleo, thank you for your input. People were asking about tooth pain and hyperparathyroidism, and here we go. Again, that's why our community matters. Moving on. Aaron Wary, I was told 24-hour urine calcium test is only to determine if FHH is present. Yes, that is if you have high calcium normal PTH or slightly elevated PTH, and they're not sure if this is hyperparathyroidism or if it is FHH. Yes, but if you have very high calcium, very high PTH, then if it's not FHH, right? It also helps in the setting of unclear patients where their calcium and PTHs are some in the normal range, and you're trying to figure out if they have something else, FHH, or if they have low calcium absorption in their intestines, or they have normal calcium and PTH. They're not responding appropriately to each other. They're both high normal, and you're trying to gather more evidence. So in cases where you're trying to gather more evidence for diagnosis, it helps. It does help with FHH, and sometimes it helps with you deciding if you should proceed with surgery, even though I don't generally use it for that sense. My test was over 400, failed. So over 400 means you definitely don't have FHH, and your 24-hour calcium indicates the amount of calcium in your bloodstream was high. Failed parathyroidectomy. No, I don't think this is going to help you, especially if your calcium and PTH are still elevated, Aaron. All right, moving on. Kelly Flanagan. Hi, Kelly. Just wondering if you've heard of calcium alpha ketoglutarate. I read an article that said it can help establish balance between calcium and phosphate in people with PHPT. I have not, I mean, I've heard of the compound, but I've not heard of it as it relates to hyperparathyroidism. I'll see if I can find something. Alpha ketoglutarate. Balance. Okay. I'll look it up, Kelly. Nikki Best. Hi, is it possible that my autoimmune disease is causing high calcium, low vitamin D, and high PTH? Here in the UK, it's difficult to get this calcium issue taken seriously. No. Not that we know. Because if there is autoimmune hypoparathyroidism, if there was an autoimmune hypercalcemia caused by an autoimmune disease, it would cause your PTH to be low. So it's unlikely this is autoimmune related. There is no recognized hyperparathyroidism caused by an autoimmune disease, right? Let me first say that. There is a recognized hypoparathyroidism because of autoimmune attack on the parathyroid, but not hyper. But if on a theoretical level it was, then it would cause high calcium and low PTH. Lisa Crawford, hi from Scotland. Hello, Scotland. Doris Melgard. Hi, Dr. Larian. So good to see you. As always, thank you for your faithful web sessions. My pleasure. Doris. Having had parathyroid surgery and now pituitary brain tumor, MEN1 gene negative, looking for MEN4 info. On bulky calcified phalanx meningiomas on pre-op before pituitary surgery CT, which can go along with MEN4. also wanting to put MEN4 out there for those who haven't heard of it. Thank you for sharing. I also know very little of MEN4, but I will also look into it. Thanks for sharing. Wish you the best, my dear. Eleonora, I just have a question for you that I consider strange. I had my surgery 2 months ago. I felt great from the moment I woke up. My question is, the first PTH taken while I was being operated was 212. After removal of 2.5 diseased glands, it came down to normal. However, before surgery, my PTH was never above 75. I don't understand that. Good question. Some of the rapid PTH test machines show much higher numbers. So it's not uncommon to have higher numbers. Sometimes the number jumps up if the surgeon did the PTH not before the operation, but rather during surgery after anesthesia was given, because some of the anesthetics cause you to have a rapid horizon PTH. Okay? Also, I never had biotin or anything that would reduce PTH. Thanks. So that's the answer. It's not uncommon. Pete Catania, Catania. Hi, doctor. I posted a question in the other comments, but don't see it here. Did I post it in the wrong place? Should I repost? I don't know, Peter. Pete, if I haven't answered your question, then post it again, my friend. Michelle Boundar Troilo. Normal patient, normal PT. Calcium has been high 10s. I guess normal PTH. Calcium has been high 10s to high 11s every last since 2012. All urine labs calcium was also high, right? I've talked to my primary doctor and about the atenolol chloride, and she doesn't think it's causing it. I don't think so either. I've been taking for 15 plus years. I'm 58 and I feel awful. I'm not living at this point. I'm just existing. Surgeons removed 2 healthy parathyroids in 2018. A second surgeon did exploratory surgery in September 2018, was unable to locate remaining parathyroids. I'm so afraid and frustrated. Michelle, you have 2 options. You can either do a PET choline scan, which if you're in the US, they offer it in the Mayo Clinic and UC San Francisco to see if you can identify the gland, or try Sensipar, okay? And if you've had 2 surgery and you were my sister, I would encourage, if you have easy access to the PET choline, I would do it right away, because if it's somewhere else and you can easily access, that's an easy solution. Or you can proceed with using Sensipar, and hopefully you won't have any side effects, which happens in a very small minority of patients rather than a majority, okay? So that is a good viable option. Best of luck, my dear. Sin Mill, all right, Sin Mill. Let me look at your info from before. So Sin Mill, you had said, what happens when PTH is normal and calcium is high, vitamin D low? All right, so my calcium is in the 20s, but PTH is normal. Sin Mill, what? Hold on, let me look at your whole message. What is the range of normal for calcium? That your calcium is in the 20s. I don't recognize that as a number. PTH. And when you say your PTH is normal, give me the range for your calcium, give me the range for your PTH, and give me your actual numbers, right? Vitamin D is 39, told to stop a month ago and retest. What does this mean if calcium is normal? So, if, let's just say your calcium is high, your PTH is normal and your vitamin D is normal. You could have very high activated vitamin D, right? And if you stop the vitamin D and your calcium comes to normal and your PTH stays in the normal range, your vitamin D doesn't drop so much, then you can assume you had vitamin D toxicity and you're all good. And if your symptoms are better, it's all good. It is not a commonly seen phenomenon for people to have vitamin D toxicity, right? Because people have such low vitamin Ds nowadays. And so I just need more information to better answer you, Sen. So hopefully you're still on and can give me. Tina Elliott, how common is it for elderly folks to have parathyroid problems as a matter of course? Well, it is more common in older population because hyperparathyroidism in most people happens from a parathyroid adenoma. Parathyroid adenomas happen because of mutations in the parathyroid cells. And the older you are and the longer you've lived, the more you've been exposed to toxins, environmental toxins, food toxins, and so on. And the more likely it is for you to get a tumor or mutations that cause hyperparathyroidism. I had parathyroid hyperplasia surgery with you in 2018. I remember it, Tina. Both of my parents recently passed away. They both had osteoporosis, heart attacks, strokes, and kidney. I'm so sorry, Tina, that must be very hard. In reviewing their medical records after they passed away, I noticed they both had elevated PTH. It makes me wonder about the genetic aspect of hyperplasia and what possible role this played in their poor health prior to death. Thank you, and I appreciate your input. So let me flip this around and show you something. I don't have a... So Gary Shandling's picture is here, not because he had a revision parathyroidectomy, but rather because he had hyperparathyroidism and he died from heart disease. He didn't have surgery or treat the hyperparathyroidism. People who have hyperparathyroidism have much increased risk of heart disease. They get heart rhythm abnormalities. There's PTH receptors on the walls of your heart. And people who have elevated PTH get thickening of their heart. They get increased blood pressure, calcification of their blood vessels, and they start getting more prone to heart attacks and so on, and strokes. And so if it may not be the sole reason why this happened to your poor parents, but it did definitely contribute. Hyperplasia definitely runs in families, and you should definitely do genetic testing, not for your sake, but for the sake of your siblings and your children. So definitely do the genetic testing, and if you need help with that, just contact my office, and my staff can send you the info on how to get the test done. Okay, my dear? Best of luck, and I'm so sorry for your loss. Annie. Hi, I'm from UK. PTH is 8.4 above normal. Serum adjusted calcium is normal. Vitamin D is at 106, which based on the US system, 106 is high. I'm not sure for you guys across the pond. I have osteopenia and fragility fractures of the ankles. 2020, not sure what to do next, as primary doctor just wants to check blood in a year. So, let's just assume your vitamin D is normal, right? And robust and healthy normal. Your calcium is in the normal range and your PTH is elevated. So you have normal calcium hyperparathyroidism. You've had fragility fractures, right, of the ankle, right? So you have an indication for surgery. You have osteopenia. And if your age is less than 50, you should push for surgery, right? Push, you should say, I've already had a fracture from a low impact situation, which I shouldn't have had. I don't want to have more fractures. The problem is in the UK, they have the NICE guidelines. The NICE guidelines is an institutional national guidelines that tell doctors what to do in conditions. The NICE guidelines came out several years ago. I talked to Fausto Palazzo, who was involved with making the NICE guidelines. They looked and analyzed hyperparathyroidism, and they find people who have hyperparathyroidism with elevated calcium and PTH. In the UK system, it was cheaper to operate on them and take care of it than to follow them for a lifetime with labs and ultrasounds and all sorts of nonsense, or deal with the consequences of hyperparathyroidism. So they don't even look at the international workshop guidelines anymore. You have high calcium, high PTH, we're gonna operate on you. And then they say nothing about normal calcemic hyperparathyroidism. Then Fausto said we carefully and cautiously avoided talking about normal calcemic because normal calcemic is such a piece of work. And it truly is such a piece of work, because I'll tell you why. Because the infamous table, because there's so many other causes of having elevated PTH and normal calciums, right? That you have to go through. And also you have to, I would urge you to try rocalcitrol, looking at 125 dihydroxyvitamin D. If that number is low, then taking rocalcitrol rather than vitamin D supplements and seeing if that fixes your numbers. And if none of these are present, right? And if you're either postmenopausal and you have tried the rocalcitrol and it didn't work for you, or if you're premenopausal, the rocalcitrol doesn't generally help in premenopausal situations, but it's worth looking at your 125 to see if you're low on 125. The other name for 125 vitamin D is rocalcitrol, right? And if that's the case, then, and of all of these have been excluded, then you have normal calcemic hyperparathyroidism, normal calciums, elevated PTH, osteoporosis, and in your case, osteopenia and fragility fractures. You're going to have a hard time in the UK system getting a surgeon to operate on you because the national guidelines are working against you. Your angle should be fragility fractures. Your angle with the surgeon is, I have fragility fractures. Fragility fractures is the key word here, right? Osteopenia, my bone density is inappropriate for my age. Obviously, I have osteopenia, but more so, for me, it's impactful. It's not only osteopenia, I get fractures from it. I really need to prevent fractures. In the long term, it would be, this is sad to say, cheaper for the healthcare system if they treated you now rather than wait to treat another bone fracture. That's more expensive than hyperparathyroid surgery. All right? Just the plates that they have to use to treat your bone fracture is more expensive than parathyroid surgery. Go figure, right? Anyways, best of luck, my dear. Leslie Halliday New, UK patients have looked for hyperparathyroid. UK Action for Change. We are a patient-to-patient advice group with lots of advice available. We all learn from each other as well as Dr. Larian. Absolutely. I support you, my dear. This is a community that needs to take care of each other. Let me throw you a like there. Joe Carroll Hughes Siborowski, aka Fonzie. Hello. Hi, Joe Carroll. I miss you. And I love hearing from you. So let's see what we have. Can you discuss what else other than FHH can cause low 24-hour urine calcium? Mine is consistently around 28. Yes, two things. Low calcium intake, intestinal issues that prevent you from absorbing calcium. In postmenopausal setting, vitamin D resistance in the intestines, because without vitamin D, activated vitamin D, rocalcitrol, your intestines only absorb 20% of the calcium you consume. with it 80%. So you know, one of the things may be just recalcitrol intake in your particular case. But those are the factors. Low absorption of calcium, low consumption of calcium. And so, you know, try that and see if that can help you out, my dear. You've been so helpful. You've shared so much. You've done so much. You're more than Fonzie to me. All right. Thank you, Joe Carroll. Wendy's son, you talked about doing fasting labs at 8 a.m. in the morning. Would doing a fasting lab only drinking water before at 11 a.m. in the morning be acceptable as well? No, it isn't. Because we have 3 known peaks in calcium. And they happen naturally during the course of our day, right? That there's probably more happening, right? Because when PTH goes up, your bones release calcium. When the PTH is down, the bones reshape calcium or reinsert calcium in your bones, and they remodel the bones to get stronger, right? This is naturally happening during the course of the day for your bones to constantly remodel themselves and get themselves stronger. We are head to toe in the constant process of regenerating, remaking ourselves. Otherwise, we wouldn't be able to live as long as we do, right? And so if you get your calcium at one of those peaks, or if you get your calcium PTH levels at one of those peaks, you may get a false elevation in PTH or a false quick drop. So at 8 a.m. is the ideal time to do it, okay? It's not a matter of being acceptable or not. It's you may be off in terms of your timing and get a false number that doesn't help you. All right, let's see if there's any more questions. Leslie Halliday, there's a very good patient to patient. Okay, we did that. Look up Hyperparathyroid UK Action for Change. Yeah, look it up. All right. Nikki Best, thank you. Sin Mill. I mean calcium is in the tens, typo. Okay. So let's go back to Sin. So calcium is in the tens, but PTH normal, vitamin D 39. Told to stop vitamin D for a month. What does this mean if calcium is normal now? So if your calcium was elevated and you stop the vitamin D and your calcium drops and your PTH continues to stay in the normal range, then you were vitamin D toxic. That's what that means. So retest, but I would say again, retest 8 o'clock in the morning, fasting. Don't take any biotin for a week or two before this. Make sure you also check not only calcium and PTH, you check ionized calcium. The other name for it is free calcium, 25 hydroxyvitamin D, 125 dihydroxyvitamin D, and if you can do a 24-hour urine calcium, that would be very helpful. All right, let's see if there's any more questions. Jenny Bell, is removing a second adenoma harder to remove than the first time around? My 85-year-old mom had parathyroidectomy last January, and they removed the one adenoma that showed on the scan. Her muddleness eased and her mobility improved significantly after a few days of an operation. So let me explain. If your first surgeon did a minimally invasive parathyroidectomy, and when I say minimally invasive parathyroidectomy, it means that it doesn't mean they use a small incision. That's part of it. But it means they only looked at the abnormal gland. They didn't go looking for the other 3 glands. If you're looking for the other 3 glands, then you're being maximally invasive under the surface. If you want to be minimally invasive under the surface, it means you look at 1 gland, not all 4. Right? And you check PTH. Right? So if they did a minimally invasive where they looked at that 1 gland, didn't look at any of the other ones, and they came out, your mom having a second surgery where they go, so let's assume they looked at the left lower one. Let me flip you around. So Ooh, let me get you to. Okay, so if your mom has a double adenoma, right, and the scan only showed this one, and they made an incision, they went here, they went all the way up there and took that one out, right, and didn't look for these three, then the area in these three has no scarring and there's no increased risk of doing surgery on these areas, right? So then no. On the other hand, if they went and looked at all four, found all four, they mucked around there, then there's increased risk. So then she says last August she started getting more muddled and her calcium pH started rising again. She's having this new adenoma out in about 3 weeks' time. It's on the same side. They've done genetic testing and it's not hereditary. However, they have said that she may not have the same improvement as the last time, as there is scarring, etc. Well, I mean, scarring has nothing to do with improvement. I would say two things. She may not have as much of an improvement because she's older and she's the disease. That's one thing. It has nothing to do with scarring. I would urge you to have them do the surgery with PTH testing, because if the fact that she failed the surgery increases the risk of her having had hyperplasia rather than just 2 adenomas. Even though it's still possible to have 2 adenomas, but doing PTH testing at least can give you further proof that that was the case, because you don't want your mom to have a 3rd surgery, okay? So do the 2nd surgery, make sure they do the PTH testing during surgery, and then they're done. And hopefully that's it. Hopefully what I'm saying is helpful. Helen Blair, hi Dr. Larian. I'm interested to know if you think there's a link between parotid tumors and parathyroid tumors. There isn't. There isn't, my dear. They both happen more often in women. And so because they're glandular tissue, and glandular disease happens more often in women because you guys create life. So as part of creating life, you challenge your hormonal systems on a monthly basis. So they have essentially more mileage on them, so they get into trouble more. It's just the nature of how things happen. But those two diseases, those two conditions are not related. There's no genetic commonality. Okay, Jennifer Conine, thank you for the opportunity to share my concerns with you. My primary doctor, holy moly, hope. Jennifer, I apologize. My nurse just came in the room and said I have 2 patients here, and your note is a long one. All right, let me see if I can answer it quickly. My doctor and rheumatologist don't believe that I have hyperparathyroidism, but I'm still concerned with my labs and symptoms. I've been suffering for years of a lot of symptoms. Can't give a reason for my high calcium lab. Would you please look over the labs and symptoms below? I should also add taking vitamin D2, 1.25 milligrams once a week to treat my low vitamin D. I began this year, years ago, also diagnosed with fibromyalgia. All right. Calcium. All right, so April 26, 21, calcium 10.7, PTH 41, ionized calcium 5.7. Then May of the same year, calcium 10.9, PTH 44. So you don't have a suppressed PTH, you have an elevated calcium, right? You need to go through the workup of hypercalcemia, looking at all the other causes that I outlined at the beginning of this talk. And once you've ruled out other causes for elevation in calcium based on that and based on the handout that's on the website, right? Then then you can firmly and strongly let your doctors know, hey, I've ruled out all the other reasons for having elevated calcium. My PTH is not suppressed. I have normal hormonal hyperparathyroidism. Then you can proceed with treatment. But it's very likely that you have it. All right, Mike. I am so sorry I have to run. Have a lovely, lovely day. It's always a pleasure to be here and be challenged by you guys. See you next month.